Hi everybody, Neil Kravitz here. I hope you're enjoying these daily clinical pearls. This clinical pearl is about diagnosing skeletal imbalances and the improvement in your diagnosis as you get more experienced as an orthodontist. I think a young orthodontist struggles with two types of skeletal dysplasias. One, diagnosing maxillary hypoplasia, maxillary deficiency, and number two, diagnosing mandibular asymmetry. Now, for maxillary deficiency, when you have a short setback maxilla, the challenge is even if you do get all the teeth in, the incisors are often flared and you get minimal incisal display in the absence of a Lefort surgery. The big concern is for labally displaced canines. When you try to move in those labally displaced canines in a deficient maxilla, you often will resorb the distal aspect of the roots of the lateral incisors, and it's essentially setting the patient up for upper extractions and a Lefort anyways. But for me, the biggest complication with maxillary deficiency is one, incisor proclination, and number two, minimal smile display because the whole maxillary complex is set back. So I have had many patients with good occlusions, but we still elect to do a Lefort advancement just so the patient can show more teeth when they smile. You'll see maxillary deficiency when the patient smiles and they show minimal teeth display. When the nose tips down, when they smile, it almost looks like a cleft lip and palate patient. For mandibular asymmetry, this can happen in the middle of treatment. It's often very frustrating when it does, when the patient begins to grow asymmetrically. Oftentimes you'll be chasing a midline and not realizing it's a skeletal problem, not a dental problem. But you really want to try to diagnose mandibular asymmetry during the consultation. A parent sometimes will not understand that this is a bone issue and they may blame the orthodontics for the lower midline deviating. I think it's also hard to diagnose a mandibular asymmetry on a class 2 patient when the mandible's retrognathic. A lot of times the maxillary dental midlines will coincide with the facial dental midline, but the mandible will be short and asymmetrical on one side. Certainly you could do a unilateral forceps or even a functional appliance, but sometimes that patient will simply have a subdivision on that side that is their skeletal alignment in the absence of a BSSO advancement. So the pearl here is just to really get practice and good at diagnosing skeletal imbalances, trace those cephs. You still need old-fashioned orthodontics, and really keep an eye out for maxillary deficiency and mandibular asymmetry in both prognathic and retrognathic patients. I hope you enjoyed this pearl. Thank you guys so much for subscribing to this channel. Thank you for supporting the JCO.